Today's topic for discussion is hyperuricemia and gout, and I'll try to make this into a case-based discussion rather than telling more theory things, so that it can be useful to all of us and the clinics. And I'll be happy if you have doubts at the end of the session, so that we can have some discussion over that also. So the overview of today's discussion, mainly there is an introduction, how we diagnose, how we treat a patient with hyperuricemia or gout. And I'll be discussing mainly few cases. And these cases are all my cases or the cases that I have treated. But there are some, I'll be showing some pictures. Those pictures are most of them are from the Google, not my own patients. Few pictures are only mine. But for to make the discussion interesting, I have taken some pictures from the Google, but these cases are all mine. And mainly, I'll be discussing some of the mistakes that I have done during my this thing, while I treated a few of the patients with gouty arthritis. So, coming to the introduction, it is the oldest known arthritis that it is recorded as back as 2640 BC from Egypt. And gout, as we all know, is the most common inflammatory arthritis in adults, caused by the deposition of monosodium urate crystals in joints and tissues following chronic hyperuricemia. It was previously called as the disease of the kings because there were only ones who were having something to eat and people who are not having anything, and only they got the disease. But nowadays, all of us, even doctors, get this disease because of our lifestyle habits. Even though it is very common, we have many tools to make the diagnosis. We have the guidelines to make diagnosis. Misdiagnosis is very common because there are many differential diagnoses can present like a gouty arthritis. And even though we have clear guidelines for the treatment, suboptimal treatment is what we usually see, and it can lead to preventable morbidity. And early recognition and rational management is the most important thing when we treat any disease, more so in gout. So coming to prevalence, in 2020, it is around 56 million in the world. And it was 22, there is an increase of 22.5% since 1990. We all know that males are more commonly affected than females, 3:1. But as age increase, prevalence become almost the same. That is, after menopause, females also get gouty arthritis. And the contributing factors are high BMI, aging population, lifestyle, and diet changes. And the number is expected to reach 96 million by 2050. But in India, the overall prevalence is very low. It is generally considered generally less than 0.5, depending upon various studies. And urban and rural areas, the number differs. But since we have a very huge population, India is considered as one of the countries with highest burden of gout. Coming to my experience, this is what I saw during the last week. I saw around 270 patients during my OPD the last 6 days. I know that most of you will be seeing more than this number in a single day. And of this 270 patients, I had only 2 gouty arthritis patients. That is only 0.7%. But approximately 20% of the patients had hyperuricemia, and most of them were psoriatic arthritis patients. Even rheumatoid arthritis patients also had hyperuricemia. So a few patients had CKD who presented with myalgia, and there were some patients with vague aches and pains who also had hyperuricemia. And the interesting thing was, in the last 1 month, I had 2 patients who presented with chest wall pain, who was referred to me because he had high uric acid and rheumatoid factor positive, and was found to have TB spine, and one multiple myeloma patient who had back pain. So in the introduction itself, what I am trying to say is uric acid, even though it is elevated, or rheumatoid factor, which we commonly see in rheumatoid arthritis, even though it is elevated, if the typical presentation of a particular disease is not seen in that patient, or the patient is presenting with atypical features, even if the blood tests are showing some factors positive, you have to look for other diseases which can have a similar presentation or a very more common presentation. So this is just theory. Gout affects the mental and physical activities. It can cause pain, it can cause damage, it can cause functional limitations, it can cause sleep deprivations. We don't Usually in our busy OP, we don't usually go into all these details because of the lack of time, and we have other big cases. Gout usually we consider this is just a elevated uric acid, and you just take this medicine and be fine. But even gouty arthritis patients can have many issues, both physical and mental, and can affect the daily activities also. It can cause anxiety, depression, can cause a feeling of isolation, and there can be even strain in family relationships. Now, another important thing, or the most important thing, is that hyperuricemia is usually seen with other comorbidities like hypertension, cardiovascular disease, chronic disease, and metabolic syndrome. So, the factors that affect the quality of life in gouty arthritis was found to be one, suboptimal management, which can lead to an increase in the frequency of attacks, and then a permanent damage. So this is again a little bit of theory that this is the uric acid pathway. The purines are the guanine and the adenosine, and this get converted to xanthine and then to uric acid by the action of different enzymes during the pathway. So why this pathway? We have certain medicines which act in different areas in this pathway so that the uric acid production can be decreased. So why we get a hyperuricemia? It can be due to two reasons. One, there is underexcretion. Two, there is overproduction. Usually, it is the underexcretion which is more common. That is, the uric acid that is formed in our body is not getting excreted in the usual way. In our body, 85% of the uric acid is excreted through the urine and 15% through GIT. And what are the factors that cause underexcretion? Usually, it is the uric. Commonly, we see is the diuretics. When there is renal failure, alcohol, which causes increased urinary reabsorption, some genetic defects also. And there are some conditions which cause overproduction of uric acid. These are the red meat, the beef, pork, lamb, the seafoods, the endogenous purine synthesis, in which we see in the malignancy, the tumor lysis syndrome, and other malignancies. Some deficiency states like HPR deficiency, PRPS deficiency, which cause some genetic disorders. And when there is a defect in the purine breakdown, like in glycogen storage disease. All these things can lead to an increased overproduction. And these two things are the factors that cause an increase in uric acid in our body. And the risk factors usually are the male sex. As age increases, obesity, diet, and genetics. Now, what happens when there is an increased amount of monosodium urate crystal in our body? And this will be taken up by the macrophages, and this causes activation of NLRP3 inflammasome. The activation of this inflammasome is very important because when there is an inflammation, it can cause dangerous repercussions, like it can cause inflammation in the blood vessels, inflammation in the bones, inflammation in the joints and the tissues, other tissues, and this can cause some of the diseases like myocardial infarction, stroke, etc., and at a younger age, which is usually don't see in that age. So there is an inflammation, and this inflammation is mainly due to NLRP3 inflammasome in case of gout, and this inflammasome activation causes caspase to active, and this converts pro-interleukin 1b into interleukin 1b, and this is then acted upon the interleukin 1 receptor, and again there is an activation increase in inflammation, and this causes increased recruitment of other leukocytes like neutrophils, and this cascade continues, and this causes inflammation, and we get pain, inflammation, swelling, redness, all those things. So this is the risk factors for hyperuricemia and gout. This I already mentioned. And the definition of hyperuricemia is in a female if uric acid level is more than 6 mg per deciliter, and in a male if it is more than 7, we call it hyperuricemia. Coming to gout,
അത് സ്ക്രീനാണ് പ്രസന്റേഷന്റെ ഇതാണ് സ്ക്രീനാണ്.
gout is an episodic arthritis. It can be monoarticular or polyarticular. Usually it is monoarticular. I hope everybody can see the screen. Everybody is able to see the screen,
Yes.
right?
Yes.
Yes.
So gout usually presents as an episodic arthritis. It is most commonly seen as it is a monoarticular arthritis. It is more commonly seen as monoarticular, but it can be polyarticular when it is chronic gout. And it's a lower limb predominant. The most common joint being first MTP, more than midfoot, more than ankle, more than knee. So it can also occur in the upper limb, but when the patient is presenting with only upper limb arthritis, before making a diagnosis of gout, we have to look for other causes. So coming to clinical spectrum, the first stage is the asymptomatic hyperuricemia, and it can, in this stage, when you check the blood, there will be uric acid, high uric acid, and this stage can last even for more than 10 years. Then coming to the acute flare stage, where there will be pain and inflammation in the joint. There will be inflammation in the nearby joints also, like bursitis. During the asymptomatic period, there can be silent crystal deposition in the joint, in the muscles, in the subcutaneous tissue, etc. During the intercritical period, that is the period between the gouty attacks, this attacks can be prolonged and it can range from weeks to even years. And during advanced gout, there will be recurrent arthritis attacks, and there will be short intervals between the flares. There will be chronic synovitis. There will be visible tophi and joint destruction. So this is the most common site of gout that we see, the first MTP joint, but it can occur in any joints, or even in subcutaneous tissue, like it can occur in the ear, it can occur in the PIP joints, it can occur around the olecranon. It can, and when it is not adequately controlled, the uric acid crystals can occur, which we call the tophi. And in an X-ray, we can see crystals of uric acid, and when it progresses, it can cause complete destruction of the joints. And sometimes it can get infected also. Then the fate of the patient is very bad. Previously, we thought that the uric acid deposition or the tophi usually do not occur in the spine, but this is the CT of a patient in which there are multiple tophi which can be seen in and around the vertebral column. So it can have a multisystem involvement, like I said previously. In the renal system, it can cause uric acid nephrolithiasis, urate nephropathy, or CKD. It is strongly associated with the hypertension, CAD, and heart failure. Metabolic syndrome as a part of obesity, associated with obesity, type 2 diabetes, dyslipidemia, insulin resistance. And this is what I said, it can cause vascular inflammation due to activation of NLRP3 inflammasome. So during the treatment, we need to keep the inflammation under control. So coming to diagnosis, clinical suspicion is the key. So this is the first case that I would like to discuss. It is a 48-year-old man who, with a past history of hypertension on thiazide diuretic and occasional alcoholic use. He presented with acute onset of severe pain, swelling, and redness in the right first metatarsophalangeal joint. And the pain started at night. It woke him up from sleep, and he was unable to bear weight. He had a similar history around 6 months back, and he was found to have elevated uric acid. It resolved within 3 to 4 days after starting febuxostat, and he stopped the medicines after 10 days. So this was the picture. And this, we know this is gout. Typical presentation, a middle-aged man who has risk factors for hyperuricemia. The first MTP joint is the characteristic joint that is involved. And typically, it starts at night. If the patient won't be able to sleep, and he will not be able to bear weight. And a similar history is there 6 months back. So this episodic arthritis, lower limb predominant, first MTP, middle-aged man, and risk factors for hyperuricemia. So all these factors are there. So most probably this is, even before investigation, we know that this is gouty arthritis. On examination, the same thing, and uric acid is found to be 7.2. ESR and CRP are mildly elevated. What we do, we did a synovial biopsy, synovial fluid aspiration, and showed neatly shaped negatively by refrigerant crystals under polarized light microscope. I know that we are not routinely doing this synovial fluid analysis during our busy OPD, but whenever we are not sure in a monoarthritis, we need to do a synovial fluid aspiration and look for the needles. And this is the appearance in a polarized light microscopy. Most of the hospitals are not having polarized light microscopy, and we can see the needle-shaped results even under a light microscope. But the gold standard for the diagnosis of gouty arthritis is synovial fluid analysis. That we have to keep in mind. So, coming to the classification criteria. In gout, we have a classification criteria. In rheumatology, most of the criteria are classification. And this is not for making a diagnosis, but to classify certain group of patients into studies. So this we usually don't use in our clinics, but this is put here just to show that in the criteria, there are clinical criteria, lab criteria, and imaging criteria. In the clinical criteria, the arthritis is of the lower, only the lower limb is involved, not the upper limb. So in this particular criteria, if the ankle or midfoot is involved, a score of 1 is given. And if the first MTP is involved, a score of 2 is given. You have to see that the upper limb joints are not involved in this criteria. And the other things, the characteristic features are there. In the lab criteria, the blood uric acid level and the synovial fluid analysis there. And if we do a synovial analysis and if crystals are not found, then a score of -2 is given. And coming to imaging, but the imaging that we use are the X-ray, the dual energy CT, and the ultrasound. In X-ray, we get usually a TOFA deposit that the uric acid crystals, or in the progress stage, there will be destruction of the joints with overhanging edges. Two, in DCT, we will be able to see the uric acid crystals that I will show a picture of that. And in ultrasound, we get a double contour sign. So it is given a score of 4. So if we take this criteria, a score of 8 or more, we can make a diagnosis of or classify the patient into gout. The total score is 23. But we have, I put this just to show that in a patient with uric acid, if only the upper limb is involved, we have to look for other cases of upper limb involved inflammatory arthritis that it is involving the upper limb. And this is the diagnostic criteria that we used previously. All the diagnostic criteria uses the same parameters, and the sensitivity and specificity is around 94 all. So the treatment I will be discussing in the next session. Coming to case 2, a 72-year-old woman who is a chronic kidney disease patient, hypertension, osteoarthritis on furosemide, aspirin, and amlodipine, presented with acute swelling, redness, and warmth in the left ankle and midfoot, with severe pain, difficulty in walking, no prior history of arthritis like this. And this was the lower limb that we see. So this is not a male, not a middle-aged, but there are some risk factors for hyperuricemia. But the pain and swelling, this looks like a cellulitis. So initially, I treated this patient like a cellulitis with the antibiotic. So this patient, even though in our OPD, the first impression that we get when such a person comes is cellulitis. So I treated her like cellulitis with antibiotic. But after 5 days of this thing, she came back. Now there was mild fever, and uric acid level was only 5.8. And the blood showed mild leukocytosis, and CRP was elevated. So I thought the patient didn't respond to antibiotic, and a second course of antibiotic was given along with paracetamol. But again, there was only minimal improvement. So in this patient, I was not able to do an aspiration. So what did I do? I did an ultrasound. And this ultrasound showed the double contour sign. A double contour sign over the ankle joint. And what is the use of ultrasound? This ultrasound, when in difficult cases of aspiration, we can do an ultrasound, and we can ask the radiologist to look for this double contour sign. What is the double contour sign? There will be 2 lines. One line will be the margin of the bone, and the other will be the margin of the hyaline cartilage where the uric acid get deposited. So figure A shows 2 thick lines. And figure B shows 1 thick line and 1 thin line. The thick line is the margin of the bone, and the thin line is the normal hyaline cartilage. Even in other inflammatory arthritis, the cartilage will be having a thin narrow line, or a hyperechoic regular line will be seen. In gouty arthritis, the cartilage will be showing a hyperechoic irregular line which is thick. So this is the this double contour sign that we get in ultrasound, which will help us in the diagnosis. Other modern technique is DCT, dual energy CT. In this, the green crystals are the uric acid crystals, and the figure A, and figure B is after treatment, 16 months of treatment with the febuxostat. The uric acid crystals have already almost gone, and the purple color is the calcium crystals. So these 2 are the modern techniques that we use for making a diagnosis of gouty arthritis. So we have to keep in mind that gout is not just a middle-aged man's big toe disease. It can occur in an elderly woman with the other risk factors for hyperuricemia. And we have to keep in mind that uric acid level can be normal in flare in up to 33% of the cases. So always consider gout in a differential diagnosis of acute hot swollen joint. Even when presentation is unusual, gout can have cellulitis-like presentation. We have to keep this in mind. Coming to case 3, is a 60-year-old male who is a diabetic with acute onset pain, swelling, and warmth in the left knee. He had difficulty in bearing weight and restricted movements. He had fever and he was very sick. On examination, this was the knee joint. Left knee joint looks swollen and inflamed. So he was initially treated with the NSAIDs. like what we do in the first this thing. But since the patient had severe pain, he came back and blood test showed ESR and CRP elevated and uric acid is 9.1. But the image X-ray done showed some changes in the left knee joint, and a synovial fluid aspiration was done, and it was purulent, and WBC was more than 50,000 with neutrophil predominance. And Gram-Scan culture showed Staph aureus. So a diagnosis of septic arthritis was made. So this is what we get in a synovial fluid aspiration. In all inflammatory arthritis, the counts will be between 2,000 and 50,000. And if the count is more than 50,000 with the neutrophil predominance, it is more towards septic arthritis. But we have to keep in mind that in septic arthritis also, only 50 to 70% of the cases we can get a positive culture or this bacteria. So the count, which is more than 50,000 with more than 90%, can help to make it diagnosis of septic arthritis. So treatment of septic arthritis is an entirely different thing. So always rule out infection in monoarthritis. So whenever possible, try to aspirate. Come to case 4, is a 70-year-old female with complaints of pain and swelling in the wrist joint, which was acute in onset, history of recurrent episodes of the same joint for multiple times. Past history, there is no major comorbidities. Even though 70-year-old, no major comorbidities. There was no history of trauma. And this was the hand. You can clearly see the left wrist is a little inflamed. So uric acid level came to be 7.5. ESR and CRP was mildly elevated. So she was treated as gout, even though the upper limb was involved, the wrist was involved. Uric acid is high. She was treated as a case of acute gouty attack, which colchicine and febuxostat. But the patient came back. And then at this time, we did an X-ray, and this showed calcification in the triangular fibrocartilage of the wrist. And this is what I said. This is the calcification. You can see here, this is the triangular fibrocartilage and it is calcified. This is the wrist joint. Now, this is the knee joint of the patient, and you can clearly see the cartilage. There is deposition of the calcium, and you can see as a line in the joint space. And this is the shoulder joint. If you can see that the yellow arrow is showing the margin of the hyaline cartilage, and that is due to this. We can clearly see this because of the deposition of calcium. So if we do a synovial fluid aspiration, we can get weakly positive by refrigerant rhombus-shaped crystals, and a diagnosis of CPPD or pseudo gout can be made. Now, the treatment in case of acute CPPD is almost similar to that of gouty arthritis, but in chronic cases, we even give methotrexate, steroids, or hydroxychloroquine. But there are no randomized control trials in case of CPPD. So this is from recommendations. So we have to keep in mind that serum uric acid is elevated serum uric acid is not always equal to gout. The elderly with the atypical sites of arthritis always rule out CPPD or pseudo gout. Coming to case 5, who is a 28-year-old male who presented with recurrent episodes of pain in the ankle joint, and he was repeatedly treated with NSAIDs for this pain. There was no prior history of toothache, trauma, or family history of gout. And this is the this is the ankle joint. We are not able to see a definite inflammation or definite swelling in the ankle joint. When we did the blood test, his hemoglobin was low, uric acid was elevated, but creatinine was also high, and urine had proteinuria. We did the USG, it showed bilateral contracted kidneys. Synovial fluid aspiration, even though done, showed inflammatory and crystals were not seen. So all elevated uric acid patients may not be having a gouty arthritis, like in this patient. Even though uric acid is elevated, his joint is not showing monosodium urate crystal. And the second thing is, in a young patient who is presenting with hyperuricemia, always we have to rule out kidney disease before treating him with multiple doses of NSAIDs. So in a patient with CKD, there can be multiple causes for pain. I'm not going into all those things. So keep in mind that don't label every young patient with joint pain with high uric acid as gout without considering CKD or secondary causes. Don't rely on only serum uric acid levels. Coming to case 6, a 25-year-old female who presented to you with recurrent episodes of pain and swelling in the right second MCP joint for the past 6 months. Each episode is lasting for only 2 to 3 days. Multiple times uric acid is done and is normal or slightly raised. There was no significant past history, no family history of gout also there. So this is not a typical picture for gouty arthritis that we all know. That this is a young, this is a female, and the our joint pain is recurrent and is the upper limb. So in such a case, we always have to rule out other causes for inflammatory arthritis, especially in a young female. So leading questions asked, she said there was fatigue, there was patchy alopecia, there is a face rash on exposure to sunlight, and there is issue of frothy urine. So examination showed alopecia areata in this patient, and the investigation showed ESR was elevated, serum uric acid is 8.2, creatinine is 1, ANA was positive, DSDNA positive, there was hypochondroplasia, there was proteinuria, and 800 milligram per day of protein, and the diagnosis of SLE with the lupus nephritis was made. So in this patient, the elevated uric acid was due to kidney disease, which is due to lupus nephritis, and the joint pain and swelling was due to lupus only and not due to elevated uric acid. So treatment is like treat the SLE. So in a monoarthritis in a young woman, always consider SLE, infection or other autoimmune causes before diagnosing gout, and always correlate clinical features like rash, alopecia, proteinuria with the labs before assuming gout. Coming to case 7, who is a 45-year-old female, the recurrent episodes of sudden joint pain and swelling for the past 6 months. There was involvement of first MTP, knee joint, MCPs, metacarpophalangeal joints, proximal interphalangeals, and attacks vary in site each time, and one joint was involved at a time. There was involvement of only one joint at a time, and the patient was getting this joint pain and swelling for 2 or 3 days. Then it settles. There was an absolutely asymptomatic period in between, and another joint is then involved. There was no history of tophi, no fever, no systemic illnesses. And examination showed this was the film, this was the picture, and this showed some inflammation in the ring finger. Uric acid was 7.2, and it was treated as with the colchicine. But again, it recurred, so we did autoantibody studies and showed RF positive and NCC positive. So in a patient with the episodic arthritis of upper limb with the rheumatoid factor positive, NCC positive or negative, and a probable diagnosis of palindromic rheumatism should be made. And this palindromic rheumatism is treated with the first-line medication as hydroxychloroquine. And with the hydroxychloroquine, this patient's arthritis frequency and the severity came down over the next 3 to 6 months. In 50% of the cases, usually palindromic rheumatism settles within 6 months. But in the other 50%, it can evolve into other inflammatory arthritis like rheumatoid arthritis. So, palindromic rheumatism, the difference between gouty arthritis is it lasts for only 1 or 2 days, and if it is lasting for more than 4 days, it is unlikely to be palindromic rheumatism. Inflammation can occur on the joint and very near to the joint also. It can occur not only in the synovium, outside the joint also, the inflammation can occur. Rheumatoid factor and anti-CCP can be positive in almost 50% of the cases. Hydroxychloroquine is the first line, but if rheumatoid factor and anti-CCP is positive, and also if the pain is not responding to hydroxychloroquine, we treat them with methotrexate. That's in the same way as treatment for rheumatoid arthritis. And the most important thing is episodic arthritis and upper limb is the predominant involvement. So upper limb predominant episodic arthritis or inflammation near joints consider palindromic rheumatism. So these are the differential diagnoses for gouty arthritis. You always rule out septic arthritis in a monoarthritis with the patient is toxic, looking toxic. CPPD, when a typical presentation of inflammation is there, especially in an older age group patient. Palindromic rheumatism, when upper limb involvement is there with episodic arthritis, reactive arthritis, and psoriatic arthritis. This spondyloarthropathy group of arthritis can have episodic arthritis, and we can just ask the patient if he had any history of psoriasis or the first degree relatives have a history of psoriasis. Then this patient may be having psoriatic arthritis, because since psoriasis is a metabolic disease, psoriatic arthritis patients can have hyperuricemia. And in these patients, when we do a joint aspiration, there will not be monosodium urate crystal. So any spondyloarthropathy, including reactive arthritis and psoriatic arthritis, can have episodic arthritis, and the history of a recent infection or a history or family history of psoriasis should be asked. Osteoarthritis, trauma, cellulitis, avascular necrosis, rheumatoid arthritis, all can have presentation similar to gouty arthritis. So the common pitfalls while making a diagnosis of gouty arthritis are relying only on serum uric acid level. It can be normal or low in up to 33% of the cases. Typical features, if present, we should always consider other differential diagnosis, and whenever possible, do a joint aspiration because we can miss septic arthritis. So coming to treatment, there can be many guidelines for the treatment of gouty arthritis, but as a rheumatologist, what we use is the 2020 ACR, American College of Rheumatology, the 2016 European League Against Rheumatism evidence-based recommendation, and the British Society of Rheumatology 2017 guidelines. So based on the guidelines only, I'll be discussing the further slides. So coming to our case one, who was having this first MTP arthritis, a clear diagnosis of gouty arthritis was made, but the physician who saw him started him on allopurinol because he knows that allopurinol decreases the serum uric acid level. But what happened? After 3 days, he came back, is worsening of pain. What might have happened? That we will see. So coming to treatment of gouty arthritis, according to these guidelines, there are 3 parts in the diagnosis. One, you have to treat the acute gout flare. The severe pain and the inflammation should be kept under check with treatment. 2, there should be urate lowering therapy, which is chronic. And 3, there should be prophylaxis for gouty arthritis, because once we start the urate lowering therapy, there is high chance that there can get a recurrence of arthritis. So prophylaxis should be there. So acute gout flare, the prophylaxis to the chronic urate lowering therapy. So coming to acute gout flare, the first line drugs that we usually use are the NSAIDs. Especially in case of CKD, we have to avoid NSAIDs. But in routine general case, NSAIDs are the first. Then we use colchicine and then steroids. The steroids can be oral, intra-articular, directly into the joint, or intramuscular. Steroid oral we use usually 30 to 35 milligram equivalent of prednisolone for 7 to 10 days. In the case of acute gout flare, usually the duration of treatment is 7 to 10 days. If the pain is not settling within this 10 days, or if it is lasting for more than 2 weeks, most probably we are missing the diagnosis, or it is not gout, the diagnosis may be something else, or in a patient with gout, there can be superadded infection, and that can be the cause for the pain. So if the pain is not settling within 7 to 10 days, then we have to look for other causes also. The other medicines that we can use in an acute gout flare is interleukin-1 inhibitors like canakinumab and anakinra. And if the patient is already on a urate lowering therapy during an acute flare, there is no need to stop. Previously, we used to stop, but now there is no need to stop. We can continue this. And previously, what we did was when there is an acute flare, we usually didn't start uric lowering therapy, but now the guidelines clearly states that we can start urate lowering therapy during an acute flare. And these are the newer medicines that are available. The anakinra, which is the interleukin-1 receptor antagonist, canakinumab, the interleukin-1 beta blocker, the rilonacept, and javakizumab. I have not used any of these agents. Canakinumab is approved by the FDA for treatment of acute gouty flare. And there are few medicines that we are using in the labs or not in the clinics, but these are the pipeline. And these are the dapagliflozin, which inhibits the NLRP3 inflammasome, the prorancasan, which inhibits the caspase-1, and the recombinant human alpha-1 antitrypsin immunoglobulin G1 Fc fusion protein, which inhibits the interleukin-1 beta. And coming to the intersymptomatic period, that is between the attacks, it is at this stage that we have to treat the comorbidities like hypertension, CKD, diabetes, obesity, metabolic syndrome, etc. We have to educate patient about the gout, the adherence to lifestyle and the treatment. We have to prepare the patient for long-term urate lowering therapy. And if prophylaxis is not started, it has to be started. And chronic urate lowering therapy, what are the indications? More than or equal to 2 attacks in a year, TOFI on examination or imaging, CKD stage more than or equal to 3, or uric acid nephrolithiasis. These 4 are absolute indications for starting chronic urate lowering therapy. And there are some conditional recommendations, like if the attack is more than 1, but less than 2 attacks per year. That means if the patient had a joint pain and swelling, which is due to gouty arthritis 2 years back, and the patient now comes. So there is no 2 attack within this year, but there are more than 1 attack. He can be started, but there is a conditional recommendation. And also the other conditional recommendation is if the uric acid is more than 9 in a young male, then again there is a conditional recommendation that chronic urate lowering therapy can be started. But more than or equal to 2 attacks per year, TOFI on examination or imaging, CKD stage more than or equal to 3, and uric acid nephrolithiasis. These are absolute indications for starting chronic urate lowering therapy. And the medications, the first line medication is always allopurinol, including in CKD. Even though allopurinol is excreted through the kidney, in CKD also, allopurinol is the first line of chronic urate lowering therapy. An alternative medication is febuxostat. These two medicines are xanthine oxidase inhibitors, which decreases the production of uric acid. Coming to the next group, which is the uricosuric, these are the probenecid and benzbromaron, which we usually don't use regularly. And pegloticase, in case of this is a uricase, which converts the uric acid into allantoin. And this is used for severe refractory tophaceous gout. And the treat to target strategy should be the motto. And what is the target? Serum uric acid should be less than 6 milligram per deciliter during the lifetime of this patient. And if the patient is having severe or tophaceous disease, so if the patient is having tophi, the serum uric acid level should be less than 5. So these are the medications that are available, but this allopurinol and febuxostat is the most common. And allopurinol, we start at 100 milligram per day, and the dose can be increased up to 800 to 900 milligram per day. In febuxostat, we start at 40 milligram, and the dose may be increased to 80 to 120 milligram. And there was a school of thought that gout may be considered as a transportopathy. That means the uric acid is transported, or it is absorbed from the kidney, or it is secreted from the tubules through urate 1 and organic anion transporters. So by inventing medicines that acts on these transport channels, we can decrease the or increase the excretion of uric acid, or decrease the absorption of uric acid. And these are the medications that works in this site, but these are not routinely or regularly used in clinics. This may be used in future years. So coming to flare prophylaxis, which is the most common thing, which is the most important thing. The indications for starting a flare prophylaxis is whenever you start urate lowering therapy, you have to initiate flare prophylaxis. And the most common, or the agent that we use in flare prophylaxis is colchicine, 0.5 to 0.6 milligram, once or twice daily is used. If the patient is intolerant to colchicine, that patient is getting abdominal pain or loose stool, or there is any allergy, even low dose NSAIDs or low dose prednisolone can also be used as flare prophylaxis. Because when you start chronic urate lowering therapy, you can get a flare of uric acid, of gout. So in order to prevent that, we have to start the prophylaxis. So coming to the different conditions, or based on different guidelines, is there any need for urate lowering therapy in asymptomatic hyperuricemia? All guidelines are saying that there is absolutely no indication for starting urate lowering therapy, that is allopurinol or febuxostat in asymptomatic hyperuricemia patient. Even though the uric acid is 8 or 9, if the patient is not having joint pain, not having kidney disease, not having urate crystals, kidney stones, there is no indication to start urate lowering therapy. Now, urate lowering then coming to this thing, the flare prophylaxis, we have to, for all practical purposes, we have to continue the flare prophylaxis up to 6 months. And according to the BSR guideline, it may be continued for more than 6 months. That means up to 3 more months after achieving a serum uric acid level, the target. So whichever is longer. And how long you have to continue the urate lowering therapy in gout? For all practical purposes, it is lifelong. That means allopurinol or febuxostat, if we are starting, or other uricosuric agents like probenecid, if we are starting, that means this all belongs to the urate lowering therapy group. And urate lowering therapy should be continued lifelong for all practical purposes. And the target uric acid to be maintained is less than 6 milligram per deciliter. If the patient is not having tophi, if the patient is having tophi, the target should be less than 5 milligram per deciliter. Coming to refractory gout or severe gout, we define refractory gout as uric acid level which is not getting controlled even after the maximum dose available for allopurinol or febuxostat. What we use a combination therapy with xanthine oxidase inhibitors and uricosuric agents. Pegloticase may be sometimes we use for severe refractory tophaceous gout, and Interleukin-1 inhibitors may be used for resistant acute flares. Now, some of the few other medicines that we use regularly, which can be useful for urate lowering properties, are amlodipine, losartan, and fenofibrate. ACTS, we are not usually using that regularly. So the FDA approved medicines are for an acute attack, it is the NSAIDs, prednisolone, colchicine, and canakinumab. And for urate lowering therapy, allopurinol, febuxostat, probenecid, pegloticase, and lesinurad. This probenecid, pegloticase, lesinurad we have not used. Pegloticase was used for one of our patients with the tumor lysis syndrome. So for all practical purposes, that this is what we usually do for a patient with who present to you with the acute attack of gouty arthritis. So we have to start the treatment as early as possible. We have to educate regarding the patient regarding the condition, what all medicines that we can use. Treat the acute attack with NSAIDs or colchicine or steroid, and we have to maybe advise regarding topical ice or rest or elevation with rest. And we have to review after 4 to 6 months. We have to assess the lifestyle. What is his diet? How is he exercising? Is he taking alcohol or sugary drinks? And we have to assess the cardiovascular risk factors also, whether there is obesity, hypertension, dyslipidemia, diabetes mellitus. We have to review the prescribed medications, because whether he is taking diuretics, which can cause hyperuricemia, and uric acid level and creatinine should be done during the review. And for all patients, there should be patient education. We have to educate them regarding optimization of weight, modification of diet, reduction of alcohol, change the medicine whenever it is possible, and to treat the underlying cardiovascular risk factors and discuss the urate lowering therapy with the patient. So in coming to urate lowering therapy, the first line is allopurinol. We have to start at a low dose, 50 to 100 milligram per day, and titrate with the 50 to 100 milligram every 4 weeks. And the target should be to keep under less than 6 milligram per deciliter. The maximum dose according to BSR is 900, and according to ACR guideline it is 800 milligram. And we have to start the prophylaxis with the colchicine 0.5 milligram BD or OD. And we should not stop allopurinol during an acute attack. And if there is any discomfort with the allopurinol, or if the patient is not getting uric acid is not getting controlled with allopurinol, we have to then switch to febuxostat 80 milligram. The maximum dose can be increased up to 120 milligram. Again, within a span of 4 weeks, we have to reassess and increase the dose. And if there is an ability to tolerate febuxostat also, then we have to switch to uricosuric agents like probenecid. And again, we have to titrate the dose every 4 weeks. Once the target is attained, we have to consider reducing the urate lowering therapy to maintain the uric acid level to less than 6 milligram per deciliter if there is no gout, tophi, and to less than 5 milligram per deciliter if there is tophi. And we have to check urate lowering therapy annually to ensure target is still maintained, that uric acid should be checked at least once in a year. And continue ULT for all practical purposes lifelong unless modified risk factors are addressed and clinical cure is achieved. So there are some conditions where asymptomatic hyperuricemia is treated, and these are as previously mentioned, uric acid nephrolithiasis, tumor lysis syndrome, and some genetic disorders. And we have to take care of the comorbidities also, and lifestyle modifications, reduction of weight, exercise, all those things we have to explain. And dietary recommendations, we have to avoid red meat, organ meat like liver, shellfish, anchovies, sardines, alcohol, high fructose corn syrup, and sugar sweetened beverages. We have to encourage DASH or Mediterranean style diet with plenty of low fat dairy, vegetables, and cherries with adequate hydration also. So what we do in the first case, we gave him allopurinol. So what was the mistake? When we give allopurinol without this gout prophylaxis, there can be a rapid lowering of uric acid level, and this can destabilize the urine deposit. This causes increased crystal shedding, and paradoxically, there can be an increase in the flare. So this is a common mistake that patients may think that allopurinol or febuxostat is causing or an increasing pain, and this can lead to poor adherence and can further lead to chronic tophaceous gout. So what should have been done? You have to treat the acute attack with the colchicine or NSAID. NSAID this should be avoided because the patient was having hypertension and he was using diuretic, or you can use the steroid also. Then before starting urate lowering therapy, always educate that there is a chance that there can be paradoxical flare. Then you have to start the gouty prophylaxis, and we have to monitor uric acid every 2 to 5 weeks or at least once in a month. So in this case, if the patient was already suppose the patient was taking the urate lowering therapy and presented with the gout, and if we stop the urate lowering therapy, what might have happened? this patient can get a rebound increase in the serum uric acid, and there can be fresh precipitation of crystals, and this can stop the process of long-term goal of maintaining the uric acid to less than 6 milligram per deciliter. So there is no evidence that continuing urate lowering therapy during an acute gout can worsen the disease. So ideally, if the patient on urate lowering therapy is getting a gouty attack or a flare, you can continue the urate lowering therapy and treat the flare as an individual attack. Then you have to continue the prophylaxis. Now, there are 6 more cases. Coming to case 8. He was a 60-year-old male who was diagnosed with gouty arthritis for the past 5 years. Now, the patient was taking allopurinol 100 milligram once daily for the past 3 years, and he was not following up with anyone. So the diagnosis was gouty arthritis. He was started on urate lowering therapy, and he was on medication for past 3 years with only 100 milligram. He was not following up, and the blood checks were not done. What happened? Gradually, he developed subcutaneous nodules around multiple joints. And now he presented with pain, swelling, and deformity of the affected joint. And this looked like this. The upper limb involvement was there. These are the typical polyarticular gouty arthritis. And someone suspecting cellulitis did an IND and which drained white chalky material. And there is a non-healing ulcer also. With some granulation is there. And the X-ray showed complete destruction of multiple joints of the upper limbs and lower limbs, so the hands and the foot, and the USG showed the double contour sign. So what mistake was done here? He was on subtherapeutic allopurinol dose, only 100 milligram daily, and the dose was not titrated just because the patient didn't follow. Patient thought that he's taking this medicine and that is only needed, but we have to inform or educate them that there should be regular follow-up in a case of gouty arthritis. And this patient unfortunately developed chronic tophaceous gout due to undertreatment and irreversible joint damage had occurred. So the thing that we have to keep in mind is there should be treat to target, and that should be the approach. And usually most of the patients need allopurinol 300 to 600 milligram or 80 milligram of ebusulfan per day for keeping the uric acid under control. And you have to prevent progression to chronic tophaceous gout. Otherwise, there should be irreversible joint damage. Coming to case 9, who is a chronic kidney disease patient with uric acid 7. So this patient was not initially having joint pain. The patient is having chronic disease and uric acid was raised. So he was advised chronic urate lowering therapy, but as the patient feared about kidney disease, he didn't take the medicine. What happened? He later developed with multiple painful flares in the feet and ankles. And later there developed visible tophae also. So the mistake was that the patient didn't start the urate lowering therapy for fear of nephrotoxicity. So when the patient is having a CKD with the hyperuricemia, the best thing is to start chronic urate lowering therapy, because not starting this thing is more dangerous than starting the medicine. And allopurinol, even though it's excreted through kidney, it is the first line medicine in CKD. And we have to educate the patient that untreated hyperuricemia is more dangerous than carefully treated urate lowering therapy. And here also the target should be less than 6 milligram per deciliter. And in case of tophaceous gout, it should be less than 5. Coming to case 10, again this patient, 50-year-old male, was diagnosed with gout. He was advised urate lowering therapy, but the patient said he will be severely restricting the diet. Diet was also explained, but the patient from somewhere found that some of the vegetables also can cause increasing in uric acid, and the patient was undergoing strict or severe restriction of diet, including tomato, curd, beans, pulses, etc. He was not on any medication because he feared that medications can cause kidney disease. Later, what happened? He developed multiple flares and eventually tophae appeared. So why? There is no study which shows that the uric acid can be kept under control, and the patient didn't follow up also. He didn't check the uric acid also. So there is no reliable study which shows that only diet can control the uric acid level. So relying solely on dietary restriction is the pitfall in this case. So these are we should encourage the patient to take green leafy vegetables, the fruits, low fat and non-dairy products, nuts, nut butter, healthy grains, plenty of water, 1 or 2 cups of coffee, lean protein like fish, chicken in moderation. We have to advise the patient to take, and we have to tell them that they should avoid high fructose corn syrup, as the candy bar, the soda, the sweet fruit juices, the beer and alcohol, the shellfish, shrimp, lobster, sardines, the meat, red meat, the processed foods, chips, the sugary cereals, ice creams, candy, all those things can cause an increase in uric acid and gouty arthritis. So we have to advise them to avoid this and take the previously said. So the patient education is the most vital thing. We have to inform them that, or we have to educate them that gout is not just a dietary disease, but a metabolic disorder requiring long-term therapy. Come to case 11, who's a 58-year-old male who was diagnosed with gouty arthritis 6 years ago, and he was on allopurinol 200 milligram with the colchicine prophylaxis. Colchicine prophylaxis stopped after 6 months. For the past 2 years, the uric acid reached target of 5.5 milligram per deciliter, and there was no flares for the past 2 years. So the doctor advised them that even the patient is not getting any attack during the past 2 years, and the uric acid is again normal. You can stop the medicine, and you can just continue the lifestyle modifications. What happened during the first 1 year, the uric acid level increased, but there was no attack. During the next 2 to 3 years after stopping urine therapy, there is a history of recurrent flare, recurrent medication, uric acid level increased to 9. The next 4 to 5 years after stopping ULT, there is cough appeared. X-rays were initially okay, but there is a decline in the renal function. And now, after 6 years, there is permanent damage and there is CKD. Now the patient is on regular medication. So this should have been, or this should be avoided when we see a patient with a gout. So we have to keep in mind that gout is a chronic urate deposition disease and not just episodic arthritis. Even though the patient is not having any episodes of inflammatory arthritis, we have to educate them that they have to take medicine. Urate lowering therapy often is lifelong. And continue lifelong urate therapy is the ideal practice to maintain a uric acid level of less than 6 milligram per deciliter. And educate the patient that absence of symptoms is not equal to cure. Coming to case 12, who is a 65-year-old male with a CKD stage 3 recurrent flares. He was unfortunately treated with the NSAIDs for flares and colchicine 0.5 milligram twice daily. That is a maximum dose of 1.5 milligram was given. What happened when the patient came back? He had recurrent nausea and vomiting. Uric acid level was 9.2 and creatinine was 2.4. That means there is a worsening of uric acid, there was a worsening of creatinine also. So we don't commit this mistake. Like in the CKD patient, we usually don't give NSAIDs. And colchicine, the maximum dose should be 1. The maximum can be 1.5, but since the NSAID was also given, there is a risk of colchicine toxicity, and this caused the diarrhea. So the current treatment should be acute flare should be treated with oral steroid or intraarticular steroid. Prophylaxis should colchicine 0.5 milligram OD should be given. The allopurinol should be the first thing to start at the lower dose. So in CKD, allopurinol is the first line medication. We are usually start at 50 to 100 milligram per day. And if the GFR is more than 60, you can start at 100 milligram per day. If the GFR is 30 to 59, start at 50 to 100 milligram per day. If it is 15 to 29, start at 50 milligram per day. And if it is less than 15 or the patient is on dialysis, 50 milligram alternate days can be given or after dialysis can be given. In case of febuxostat, again, there is a reduction. When the GFR is more than or equal to 30, there is no need for any adjustment. But if it is less than 30, there is only limited data. So we usually don't use febuxostat in such patients. Again, coming to the dose of colchicine, the maximum dose should be 1.5 milligram in 1 day. But in a patient with CKD, this should not be repeated within 14 days. And if the patient is on dialysis, a single dose of 0.5 milligram is to be given. So coming to case 13, who is a chronic liver disease female patient diagnosed with gouty arthritis. The patient was started on febuxostat. Uric acid was 8.7. He was started on febuxostat. What might have happened after 3 weeks? There was worsening of liver function, and there was more than 3 times upper limit of normal. Why? Febuxostat is metabolized through the liver. So in a patient with the chronic liver disease, it is ideal to start him or the patient on allopurinol. And febuxostat should not be started. So we have to monitor LFT. Even though patient is on allopurinol, we have to monitor LFT regularly. And this is the last case. It's a 14-year-old, case number 14 is a 60-year-old male with past history of CAD on low dose aspirin, and he was diagnosed with SLE and he was on azathioprine. And now he developed monoarthritis, and uric acid was found to be 8.9, and he was started on allopurinol 300 milligram OD. After 1 month, he came with fever and mucositis. He was febrile. There was arthritis. There was oral erosions. Uric acid was 7.8, and the blood count showed pancytopenia. There was low hemoglobin, low total count, and low platelet. What might have happened? The patient is on azathioprine, and the patient was started on allopurinol. There is drug interaction between azathioprine and allopurinol. So the allopurinol inhibits the xanthine oxidase inhibitor. So azathioprine is converted to cis-mercaptopurine, and which is again converted to 6-thioguanine metabolites. 6-mercaptopurine is acted upon by xanthine oxidase, and 6-thiouracil and 6-methyl mercaptopurine is formed. But when allopurinol is used, what happens? All the azathioprine will be converted to 6-thioguanine metabolites, and this causes an increase in apoptosis of WBC and myelosuppression, and this causes pancytopenia. So whenever we are using chronic medications, always think about, always check the drug interaction when we are starting some new medicines. So the correct treatment should have been, you have to avoid full dose of allopurinol, and when you use along with azathioprine. Reduced dose of allopurinol and reduction in dose of azathioprine might have been helped him, or we can switch the azathioprine to mycophenol mofetil if it is clinically appropriate. And febuxostat again interacts the similar way as allopurinol, so the same result can occur. So there is some drug interaction like allopurinol when used along with azathioprine, theophylline, warfarin can cause toxicity, and the AC inhibitor thiazides and antibiotics like ampicillin or amoxicillin can cause hypersensitive reaction due to allopurinol. And febuxostat, we have to keep in mind that the dose should be when used along with azathioprine, theophylline, and iodinosin. And coming to colchicine, again, we use this regularly for up to 6 months. So again, when we are using new medications, we have to check the drug interaction because colchicine is metabolized by CYP3A4. So when we use a strong inhibitor like clarithromycin or voriconazole or ketoconazole or treatment of HIV or calcium channel blockers like verapamil, diltiazem, etc., it can cause increase in level of colchicine and can cause toxicity. And again, colchicine is a PGP or a P-glycoprotein substrate. So other substrates which are cyclosporin, tacrolimus, amiodarone, etc., can again cause, when used along with the colchicine, can cause its toxicity. And the statins, when used along with the gout, can cause myopathy. Colchicine can cause myopathy or rhabdomyolysis. When used along with fibrates, can cause myopathy. And when used along with digoxin, can cause toxicity of both. So this is the last slide. And the take-home messages would be, avoid diagnosing gout based on only serum uric acid level. The typical features, if present, we have to look for other causes for arthritis and secondary cause for hyperuricemia. In monoarthritis, always rule out infection and treat each flare as separate event. Start prophylaxis during the start of urate lower therapy, and you have to prolong urate lower therapy, sometimes lifelong, or most all practical purposes it is lifelong. And look for drug-to-drug interaction because we need long-term treatment, and lifestyle modification and treatment of comorbidities is equally essential as the other medicines. And the most important thing is educate the patient that gout is a treatable metabolic disease requiring long-term treatment and follow-up, and complications are absolutely preventable. Thank you. Thank you for the patient hearing.
Thank you, Dr. Harikrishnan. Participants, you can unmute and ask. One question. Many TB patients on ATT, INH develop hyperuricemia. Do we need to treat if they are asymptomatic? If symptomatic, how long should they be treated?
Hello. On patient with on ATT, most probably it is due to the medicines that we are taking for ATT. No? So if the patient is symptomatic, then we have to treat it with colchicine or similar way as treatment of a gouty flare. And if we are able to stop the culprit drug in ATT, then if it permits, then that doing that alone can help. And there is, if the uric acid elevation is due to ATT medicine, that we are sure, then after the end of ATT, we can very well stop the treatment.
Unmute the questions ചോദിക്കാം.
Sir, hello.
Please.
Sir, 15-year-old boy, obese ആണ്. വേറെ ഏതോ ഡോക്ടർ കണ്ടിട്ട് അവര് യൂറിക് ആസിഡ് ലെവൽസ് were 10. വേറെ എനിക്ക് ഫീവറിന്റെ ഒപ്പം കുറച്ച് ഏക്സ് ആൻഡ് പെയിൻസ് ഉണ്ടായിരുന്നു, അതുകൊണ്ടാണ് തോന്നുന്നു യൂറിക് ആസിഡ് ചെയ്ത്. വേറെ അല്ലാതെ ആർത്രൈറ്റിക് ഫീച്ചേഴ്സോ വേറെ കിഡ്നി സ്റ്റോൺസ് ഹിസ്റ്ററി അങ്ങനെയൊന്നുമില്ല, സിംറ്റമാറ്റിക് ആണ്. പക്ഷെ യൂറിക് ആസിഡ് വാല്യൂ 10 ആണ്. അപ്പൊ സർ അത് എങ്ങനെയാ പ്രൊസീഡ് ചെയ്യേണ്ടത്? അബ്സല്യൂട്ട് വാല്യൂ മോർ ദാൻ 9.5 അങ്ങനെ എന്തെങ്കിലും?
അതായത് അത് ACRന്റെ ഏറ്റവും പുതിയ 2020 വന്ന ACR ക്രൈറ്റീരിയ വെച്ചിട്ട് അതൊരു കണ്ടീഷണൽ റെക്കമെൻഡേഷൻ ആണ്. മോർ ദാൻ 9 ഇൻ എ യങ് മെയിൽ യു ഹാവ് ടു ട്രീറ്റ്. ഇറ്റ് ഈസ് ബെറ്റർ ടു ട്രീറ്റ് ദാൻ ലീവിംഗ് എന്നുള്ളതാണ് ഏറ്റവും പുതിയ 2020 വന്നതാണ് ഏറ്റവും പുതിയ, അതിനുശേഷം വന്നിട്ടില്ല. അപ്പം അതിന്റെ ലോങ് ടേമിലേക്ക് യൂറിക് ആസിഡ് ലെവലിൽ നിന്നാൽ പിന്നീട് കാർട്ടൈറ്റിസ് വരാനുള്ള റിസ്ക് ഉണ്ടെന്നുള്ള ഒരു കണക്കൂട്ടലിലാണ് അവരങ്ങനെ പറഞ്ഞത്. പക്ഷെ പേഴ്സണലി ഞാൻ യൂറിക് ആസിഡ് ലെവൽ 10 ട്രീറ്റ് ചെയ്തില്ല. ആ പേഷ്യന്റിന് മീൻസ് മെറ്റബോളിക് സിൻഡ്രോം ഉണ്ടെങ്കിൽ ബൈ അതർ ലൈഫ് സ്റ്റൈൽ മോഡിഫിക്കേഷൻസ് ആ മെറ്റബോളിക് സിൻഡ്രോമിനെ കൺട്രോൾ ചെയ്യാൻ വേണ്ടി ശ്രമിക്കുകയായിരിക്കും ചെയ്യുക. മെറ്റബോളിക് സിൻഡ്രോം കൺട്രോൾ ആയതിന് മീൻസ് അതിന് ശേഷം എനി സിംറ്റംസ്. പക്ഷെ ഞാൻ യൂറിക് ആസിഡ് കൂടാൻ വേറെ എന്തെങ്കിലും കാരണം ഒന്നും കൂടി നോക്കണം. ഇപ്പോൾ കിഡ്നി ഡിസീസോ അല്ലെങ്കിൽ വേറെ ഇത് കൂടാനുള്ള കാരണങ്ങളുണ്ടോ എന്നുള്ളത് നോക്കണം. പേഷ്യന്റിന് യൂറിക് ആസിഡ് മൂലം റീനൽ സ്റ്റോൺ ഉണ്ടെങ്കിലോ നമുക്ക് ട്രീറ്റ് ചെയ്യാം. ഇതൊന്നും ഇല്ലെങ്കിൽ ഐ വിൽ കീപ് ഹിം അണ്ടർ ഫോളോ. I will advise them lifestyle modifications with the diet and exercise.
So, lifestyle modification advice ചെയ്താ like after how many weeks should we repeat this uric acid?
Uric acid should be repeated every 2 to 5 weeks. I usually do every monthly.
Okay, sir. Thank you.
Sir, hello.
Please, please.
Sir, is there any case where we'll have to rely upon synovial fluid analysis for diagnosis?
For diagnosis of gouty arthritis?
Yeah.
Whenever possible. Synovial fluid analysis is the gold standard. If you can demonstrate a monosodium urate crystal in polarizing light microscopy, then we need not do anything else to make a diagnosis of gouty arthritis. But usually it is very difficult to get polarizing microscope. Even my center is not having any this thing. And whenever when you send the patient outside also, usually I didn't get till now I have not received any positive response like this is positive. But when I was in Amrita, we did that, means routinely did that, and we get plenty of patients with gouty arthritis with polarizing light microscope itself. So it is if you ask if is it absolutely essential, what I usually do is when I suspect a septic arthritis, I do this thing, synovial fluid analysis, but not to make a diagnosis of gouty arthritis. And also usually I do synovial fluid analysis when the joint is large joint, like a knee joint or the elbow joint. Like large joints only I do, not the small joints, because it is very difficult.
Sir, if the joint is inflamed and is swollen, but the count is normal.
The count means synovial fluid count.
No,
Or
I mean the blood count. TC is normal.
Blood count.
Yeah, blood count is normal, but the joint seems to be inflamed, swollen, reddish, everything. So
monoarthritis.
Can we? Pardon? Yeah, monoarthritis.
Monoarthritis. Only one joint is involved.
Only one joint is involved.
Yeah.
So in that case, can we treat it as just a gout and not an infection?
Yes, we can treat. The thing is to make a diagnosis of.
I mean, uric acid is elevated, but the count is normal.
Yeah, that can happen in gouty arthritis, right?
Just
so we can treat, but that is not a definite diagnosis. That's what I said. And the arthritis should not be the first episode. If there is a history of monoarthritis, if there is a history of episodic arthritis, if the lower limb was predominantly involved, upper limb not involved, typical of gouty arthritis, then there is no need for a synovial fluid analysis. But the patient is coming to you for the first time with the knee joint involvement, and even though the count is normal, it is always better to do a synovial fluid analysis.
So for CPPD, there is no specific treatment, right?
For CPPD, in the acute attack, we treat similar to acute gouty arthritis. In chronic, sometimes they can go in for long duration. So we usually treat in the same way as rheumatoid arthritis with methotrexate, other disease modifying agents. There are no randomized control trials for CPPD disease. This is from recommendations from seniors, like that.
Role of coffee in hyperuricemia. Is it black coffee? What is the quantity you advise?
And there are no studies to show that taking coffee decreases the amount of, or the amount that will decrease the amount of uric acid. Usually we advise to reduce the amount of tea and
No, I
consume
mean,
coffee.
do you use CPD or just
Can you repeat that? Hello? Can you repeat that, please?
Role of coffee in hyperuricemia. Is it black coffee? What is the quantity you advise?
And that's what there are no evidence or no studies to prove that a particular amount of black coffee can reduce the amount of gout, so uric acid in our blood. Usually what this is from maybe some few small studies that the tea when you consume more amount of tea, that can cause an increase amount of increase in the level of uric acid, and coffee can decrease. That's all. Usually what we advise is, this is not a recommendation, what we advise is to take plenty of fluid, any fluid, so that a more amount of uric acid can be removed through the urine. That's all.
So a small doubt for CPPD, do you use the DMADs?
Yes. For chronic CPPD, we treat with methotrexate, leflunomide, hydroxychloroquine, just in the same way as we treat spondyloarthropathy or rheumatoid arthritis. Yes.
Or any biologicals along with it? No, right?
Biologics? No. We have not given biologics. No.
Hello, you can ask. Can hyperuricemia cause enthesitis without acute attack of gout?
Hyperuricemia, no.
Sorry.
Only thing is this, in hyperuricemia, tophae can occur not only inside the joint, it can occur around the ligaments, around the tendons, subcutaneously in the muscles, anywhere tophae can happen. And enthesitis is characteristic of spondyloarthropathy, like ankylosing spondylitis, psoriatic arthritis, reactive arthritis, IBD-related arthritis. So on all these conditions, this spondyloarthropathy can have a metabolic component also. As part of the metabolic component, there can be hyperuricemia. So enthesitis, can it be due to hyperuricemia? I don't think so. But in spondyloarthropathy, where there is enthesitis, there can be hyperuricemia, because it is all these things are metabolic disorders.
Any particular reason for uric acid to be in the appendicular skeleton and not in the axial skeleton?
No,
nowadays, febuxostat is used more than allopurinol. What is your opinion about preferring febuxostat? Any contraindication for febuxostat?
All guidelines are recommending allopurinol as the first line medication. But the problem is allopurinol, we are using more of febuxostat because there is a fear of hypersensitivity to allopurinol. Now, hypersensitivity to allopurinol is more commonly seen in Japanese population, where there is a HLA 5801. There is some mutation in which there is in the patients with such mutation, there can be allopurinol toxicity, and there can be allopurinol hypersensitivity also. So that is the reason why we are using more febuxostat nowadays. But that is very rare in our population. And for all practical purposes, the first line medication should be allopurinol. And if there is any risk of any incidence of allergy in the first thing itself, we have to stop that. Then we can change to febuxostat. Any contraindication in chronic liver disease, usually we don't use febuxostat because it is metabolized through the liver. And there were a few studies which showed that febuxostat can increase the cardiovascular risk, but the results from different studies are different. So
participants can ask.
In general, we can use if allopurinol is contraindicated or if there is any history of intolerance to allopurinol, we use febuxoside even in cardiovascular disease patients also.
Participants can unmute and ask doubts. Otherwise, we are planning to end the session.
pregnancy അതിലെന്തൊക്കെ ശ്രദ്ധിക്കണ്ടേ പ്രഗ്നൻസി സാധ്യതകളുണ്ട്
Can you repeat that?
ഗൗട്ട് ഇൻ പ്രഗ്നൻസി ആണ് ചോദിച്ചെന്ന് തോന്നുന്നു.
അങ്ങനെ തോന്നുന്നല്ലേ
Usually,
Hello?
females in the menstruating age group don't get gouty arthritis. Why? Because estrogen is uricosuric. So whatever uric acid is formed inside our body, it will go through the urine because of the action of estrogen. So if the patient is having hyperuricemia and the patient is menstruating, we have to look for other causes for hyperuricemia and treat the other causes. It is always better to not keep a diagnosis of gouty arthritis in menstruating females or females in the reproductive age group. That's what I mentioned. This thing, sir, what to do for a 45-year-old male with CAD developed hyperuricemia and 1 episode of gouty arthritis after taking low dose aspirin antiplatelet. So we know that aspirin can cause hyperuricemia. So in this patient, it is always important to keep him under follow-up and look for uric acid level. And since there is only 1 episode of gouty arthritis, there is no recommendation to start uric acid lowering therapy. We have to treat the acute gouty attack as we have to treat that acute attack with any of these medicines. Like maybe better to avoid NSAID. You can use treat with the colchicine, or we can use steroid for 7 to 10 days and to look for a resolution of symptoms. But if the patient is getting a second episode, we can very well start urate lowering therapy if the patient can afford only aspirin, or if the cardiologist agrees with the cloplet or any other antiplatelet, we can change aspirin to antiplatelet, other antiplatelets. Any role for zinc in rheumatoid arthritis? As far as I know, I don't know anything about, and none of the recommendations, none of the guidelines recommend zinc in the treatment of rheumatoid arthritis, and I am not using that. I don't know anything about that. When is the urate lowering therapy started after an acute attack? During an acute attack, we have to treat the attack, and the patient is not on urate lowering therapy. The current the recommendation is to start. We can start urate lowering therapy during that acute attack, and if the patient is already on urate lowering therapy, we can continue the same.
Hello.
Hello. Right.
ആർക്കെങ്കിലും ഇനി അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം, ഇല്ലെങ്കിൽ നമ്മൾ സെഷൻ വൈൻഡപ്പ് ചെയ്യാൻ പോവാണ്. Okay, thank you, Dr. Hari, for the excellent session. I hope participants had learned from this session. Thank you for taking time from your busy schedule for giving us an exposure about the topic. Thank you once more. We can end the session.
Thank you, sir. Thank you for the opportunity, and hope I'll be able to associate with you in future also. Thank you.
ഒരു സെക്കൻഡ് ഹരി, റെക്കോർഡിംഗ് ഒന്ന് സ്റ്റോപ്പ് ചെയ്തേക്കോ. യുവർ ഹോസ്റ്റ് ബട്ടണിൽ ഒന്ന് ഞെക്കിയാൽ മതി. റെക്കോർഡ് ബട്ടൺ എന്ന ഓപ്ഷൻ വരുമ്പോൾ സ്റ്റോപ്പ് റെക്കോർഡിംഗ് കാണും.
സ്റ്റോപ്പ് ഷെയർ മാത്രമേ കാണുന്നുള്ളൂ.
അല്ല, സൈഡിലോട്ട് സ്ലൈഡ് നീക്കിയാൽ മതി. ഇല്ലെങ്കിലും കുഴപ്പമില്ല, ഓട്ടോമാറ്റിക് റെക്കോർഡ് സേവ് ആയിക്കോളും.
സ്റ്റോപ്പ് റെക്കോർഡിംഗ് സ്റ്റോപ്പ് ചെയ്യാം.
ഓക്കെ.